our advocacy webinar on mobile lung cancer screening units. I want to thank everybody, all of our participants for joining, and I suspect more and more will continue to roll in. Hopefully, this is a valuable session with a few of our esteemed colleagues who have various degrees of experience either establishing or running a mobile lung cancer screening program. We're going to be respectful of everybody's time on the webinar and keep this to 30 minutes. So hopefully it'll be a high yield, quick session here. Without a doubt, everybody on this webinar understands the fact that lung cancer is leading cause of death in the United States. And at this point, we have now several randomized controlled trials that have shown lung cancer screening with CT scans decreases lung cancer specific mortality. This is a beneficial strategy in lung cancer care. However, access remains a barrier for various reasons. The reasons for access being a barrier to lung cancer screening may be outside of the webinar tonight, but suffice it to say, if we can bring lung cancer screening to our patient population, there is undeniable benefit to doing so. So tonight we're going to talk about some of the strategies our colleagues in the STS are using and resources that are available to start a mobile lung cancer screening program. And I am joined by three panelists here, as I mentioned, who have either started a mobile screening program or can speak to some of the barriers and how they are overcoming these barriers. First, I'm joined by Dr. Hennin from Roswell Park. Now, they rolled out the EDDY, or Early Detection Driven by You mobile screening unit in late 2022. They've screened at least 1,200 individuals at this point, detected 5 early stage lung cancers, and this program was funded through a New York State grant of $4 million. Dr. Stephanie Worrell from the University of Arizona started looking into mobile programs in January of this year, 2025. For her and her program, the most daunting aspect was the financial piece, given that the institution had other financial priorities at that time that were taking precedence, something that I think many of us feel similarly about. They used the STS toolkit, which we'll get into, to conduct their initial steps and have started on a business plan after getting buy-in from leadership. So a situation that I think resonates with many of us here on the panel, as well as our STS membership. And Dr. Sean Jordan at the University of Tennessee. Dr. Jordan successfully wrote the proposal and grant letter to receive funding through a congressional earmark, as well as a grant funding from the Tennessee Department of Health. Dr. Jordan's program is currently in the process of building their mobile screening bus, with delivery expected, and you can correct me, Dr. Jordan, later in this coming December. So at this point, we're going to get into a panel discussion. I would encourage all participants to use the Q&A function that you'll find at the bottom of your Zoom screen to enter questions. And we will get to those questions at a question and answer time a little bit later in this call. So without further ado, we'll get into the panel discussion. The first question goes to Dr. Jordan. Dr. Jordan, can you explain how you received funding for your unit? Clearly, this is a key consideration in the process of obtaining a mobile screening unit. And what did that process look like for you and your team?
Sure. So there were a couple aspects to it. One is that just getting leadership buy-in, but just because leadership buys in doesn't mean that they're going to give you the money. So that they saw the value of the program, but they had other priorities at this time. So we have basically someone who does government relations for our hospital, and they have their ear to the I guess their finger on the pulse of the political situation, and they became aware of a grant opportunity through the U.S. Department of Agriculture through our congressional representative's office. So we kind of wrote up a hasty grant proposal to them. Rural health is being a priority now in East Tennessee as well as the rest of the country. And that helped us get a $2.3 million federal appropriation from the U.S. Department of Agriculture. Now, that money was strictly for the cost of the bus itself, and then we also used it to get some software to help manage the program, but it could not be used for personnel. And that's the other thing that you have to think about as you develop this program is, okay, you've got the bus, but who's actually going to run the program itself? And so we also separately applied for and were successful in getting a $5.4 million grant from the Tennessee Department of Health because they also have a rural health initiative. And this kind of became available in early 2025. We wrote the grant in January and heard back in April 2025 that basically it's applied the personnel to actually be on the unit itself. And that means like this, the salary for the CT tech, the registrar, the nurses, we have a psychologist that's going to be part of the program. Some of that grant money was also tied to our mobile breast cancer unit as well, but the focus of it was on the mobile lung cancer screening unit.
Terrific. Comments from other members of the panel, Dr. Worrell, Dr. Hennon? Co any comments in relationship to how we should best receive funding?
I think you brought up some really great points. The first one being that I think when I first started this, I underestimated how expensive it is because it's not just the bus, it's all the people and all the things you need around it. And then also tying to your breast cancer screening. We've been talking about that as well. And I think that's just some clever ways in which to, get more people and that can help, offload that cost a little bit. But yeah.
Dr. Hennon, your thoughts on this? I mean, your program's up and running. You've screened folks through the mobile process. Let's talk about funding for you guys.
As you mentioned, the funding for our program came similarly through government grant funding from New York State. I would echo the importance of what Dr. Jordan was talking about um, you know, focusing on funding and supporting everything outside the actual physical mobile unit that's going to lead to success. A lot of effort has to go in terms of coordinating the visits, scheduling patients, and most importantly, as we all know, the follow-up that's necessary in terms of having the planning, staffing, networking to make sure the patients are followed up on once they've had their initial.
Terrific. Let me just make sure we're getting a comment here. Okay. Dr. Worrell, could you comment a little bit about some of the specific barriers for your institution and your experience when it comes to funding the mobile unit?
Yeah, it all probably depends on what step you are as far as your lung cancer screening program overall. Ours was in the fairly early stages to begin with. So we started our lung cancer screening program in January 22. And so there's a lot of pieces of other things that we needed to build before we could allocate funds to the mobile unit. So I think that one barrier was just like timing wise, like, are you ready to, is this the right time for you to get a grant and do this whole project? And then buy-in from like having them understand like downstream revenue and the fact that like we are helping out the community, but it's not something that's like so obvious within the hospital that we're used to asking for as far as like capital purchases. Like I need a new robot, but this is like a whole different thing, and so it requires a lot more conversations outside of maybe the typical people you go to. As far as not just like your COO of the hospital, but also like we have a cancer center and just involving a lot more people. And also, as you'll probably get to, the toolkit helps with understanding that. I didn't know a lot about like our government liaison and stuff, and all of that is in that toolkit, like who you need to enlist in order to kind of be most successful.
Yeah, Dr. Worrell, I couldn't agree more. I mean, we're in the process at our place going down this road as well. Not quite as far along as the three of you, but that I think is a key component. So working with our STS advocacy team as well has been super helpful for us because they really know who you should call and they're familiar with all of the representatives in your state, et cetera. And then I think I appreciate the call out to the toolkit. We'll get to that. And I think we just put the toolkit web address, which I would encourage all of our participants to click on the chat and to go ahead and link over to the toolkit. I think you'll find it extremely helpful, and we'll get back to that a little bit later in this call. But the idea of working with government liaison and folks who can help you with your government relations is critical in this process. Um, Dr. Hennon, let's talk about the fun part. Can you talk about some success stories or case studies that really highlight some of the impact that mobile screening has had, and maybe a call out specifically to how that would have been a challenge in the absence of a mobile program?
If first things first, are people hearing me better? I did
Much
try to
better.
adjust my
Now
mic.
you're crystal clear.
Oh,
Yes,
good.
I think
Okay.
so.
Sorry
Thank
about
you.
that. But yes, as you mentioned, we've diagnosed, it's now, I got updated data. We've screened like 1,700 patients, and it's actually 7 lung cancers, but I've also diagnosed some extrathoracic malignancies as well. And so I think the success, aside just from the imaging, is, and some of the maybe offline questions, I'll get to this, but it's taking the screening to areas where patients may not be, seeking care or on the radar or getting these scans where it's just not as easy to do. And so it's always, a success story to diagnose something at an early stage, to do it and hear from family where, the patient may not have seen their PCP in a long time. So it just increases access, which is, I think, what's probably most important and gratifying.
Fantastic. I think, some of the stories that we hear as well are this is just an initial touch point, as you're alluding to, where, not only are we getting patients in who would not have been screened appropriately for lung cancer, but in many circumstances, this can be that initial touch point with the healthcare system, and really getting them in for more comprehensive care that they may be missing. So I think that that's an added benefit here. Now, a question for all three of you. What is the number one thing that you want others to know when it comes to funding or operating a mobile lung cancer screening unit? Presumably, the folks on the call here are some of the folks who are most interested in really pulling the trigger on this process. So, how can they avoid some of the mistakes or some of the longer runway that you guys may have had to pursue now that we have some programs up and running? I'll start with you, Sean.
Sure. So I think probably the biggest mistake that I made at the beginning of this when I started this process in like 2021 was thinking that the hospital was going to give me the money to do this. And it's, everyone on this, in this panel is a surgeon and they all see the downstream benefits of it. But the hospital has very different priorities than what you or I may see there. And they may not completely understand, lung cancer and the management of lung cancer, a lot of us do. So I think that getting that buy-in from the hospital is important. But it's also you're not going to get the money from them though, unless you happen to have a very generous hospital. I think it's understanding also where you can get the money from. So I never didn't even know we had a government liaison until probably about 2023, and then that person's been my best friend throughout this entire process, because they've really helped us a lot. I'm going to give a shout out to Dr. Hedrick down in Chattanooga, who has helped guide us through the process, and they have a successful unit, but they funded theirs through private donations, so it's a very different payer mix, and so that's something to think, or very different payer source. So that's something to think about. That if you've got wealthy donors, that this is a potentially major product that they could fund. But I think in different states it looks different things, and in different hospitals like different things.
Yeah, I think that's a great call out, and I'm gonna make a quick comment before I go to Stephanie, Dr. Worrell, is that you mentioned Dr. Hedrick's program, and I think they have done a great job, and he has published on mobile screening. So I would encourage anybody really interested and looking to arm themselves with some data to check out the publications by Dr. Hedrick's group. We can certainly put those either in the chat or in follow-up information for the attendees of the webinar. But they've published everything from their profitability margin to their rate of follow-up and their rate of return on diagnoses, et cetera. So I think really arming ourselves with data for why lung cancer mobile screening is beneficial is helpful when you end up going for the talk to your administration and make a case for this. Dr. Worrell, same question to you. What have you learned that you would like others to know?
Yeah. Those were terrific points, Dr. Jordan. And as far as like where to get funding and how to look for different sources, I'd say when you're starting, the nice part, I'll bring up this toolkit again, is that there is like a template for how to make a budget as far as when you're making for this platform. And it also has like actually how much the costs are for each of the things, which maybe you don't want to spin your wheels looking for, like how much is it going to cost to buy this semi and like put it all together. There was also a really good podcast in the Thinking Thoracic on the mobile screening as well, which talked a bit about that too, as far as like how to get your budget together. I think that's the key first step is you want to have a really good idea about what your budget is before you go talk to people, and then, kind of get everyone else on board.
And I just had one more thing, Elliot, as well, is that like rural health is very hot right now, especially with the big beautiful bill. I think it's under a new name now. But this is a great time to talk to your government liaison and your representative because they are looking for projects to fund, and this is a perfect project for that.
And Dr. Hennon, same question for you.
Yeah, I'd say, once you have the funding in place, then you have to start to strategize about kind of like what your timeline is. Some of the things, once our funding was in place and we wanted to get the unit up and running kind of most efficiently, made some simple decisions about leasing a vehicle versus buying one up front, right? Can be outfitted quicker. You're not committed to it long term. What we learned over time was that actually it's probably better long term to own a vehicle. But at the same time, with our lease, we learned things like a tractor trailer might be hard to navigate and park in certain areas in terms of depending on where you go. Just very practical things like that. And then as to the nuts and the bolts of working with insurance carriers, there's been at least two local insurance carriers here who have kind of waived the prior authorization for these scans, which makes it much more easy to do these. And then the planning, like we're planning the visits for each mobile unit 6 months in advance, networking and communicating with the primary care offices to ensure that there's 20 slots, filled. That's what our unit can do in one day, which maximizes the amount of scans that are being done. And the more efficiently it's used, the better it's going to be for the bottom line.
Well, Mark, you touched on a great point, and one of the first questions we got through the Q&A here, I'll bring up right now, and that's that a question about renting a unit, or you mentioned leasing. Could you give us a little bit more granular details on that? Because it sounds like you have some experience with that. One of the questions here talks about how did you overcome ACR accreditation burden, et cetera. Does anything change or lessons that you in retrospect realize now about renting/leasing versus owning and buying a vehicle, a bus?
I mean, things that wouldn't have been maybe immediately apparent, right? When you lease the truck, then you're kind of, then the leasing company also provides the driver, right? And then you're beholden to the contract of something like of a truck driver, who's got specialized training for such a unit. And so those are things that actually began to impact, like what is in a contract? How many trips will they make? How often can the truck be moved in a week? And so if you own a unit and can employ your own driver and maybe do it on a non-tractor trailer type vehicle, it becomes more nimble, I guess, in terms of the amount of locations you can take it and things of that nature. I did see a question pop up. I don't know. I wasn't part of discussions with the insurance payers in terms of how we were allowed to waive the prior authorizations. It's only two carriers that have done that, but that has helped.
Stephanie and Sean, do you want to both speak maybe to that question since we brought that up? And maybe you aren't far enough in the process yet, but in terms of how you're billing for the scans and what you're doing with prior authorizations, any comments there? I know this is also something that can be found on the toolkit, but may also be regional or hospital, dependent. Go ahead.
I was just going to say our plan is to bill insurance just as we would for a terrestrial-based lung cancer screening unit. That helps prove some of the viability for the hospital side as well. We personally have a gift fund set up for free screening for people who can't afford it. On our terrestrial side, that is a very underutilized option. Most people have insurance and meet the criteria for that. So it really has not been an option on the terrestrial side. I anticipate that as we get into the rural communities, that's going to become more of an issue. But for right now, how we're doing it's probably similar to how Dr. Hendon's group is doing it, that people are going to come in ahead of time, get all the prior authorizations wherever need done, and then bill through insurance like standard. That is our current plan.
That's our plan as well. Yeah, we haven't had any insurance that don't require prior auth successfully yet. So, but we haven't obviously started. So, but those are some of the discussions we've had.
Great, thank you. Lots of questions coming in, which is fantastic. I do want to also call out that Dr. Hedrick is on the call here and has put his email and phone number in the chat for his guidance and assistance as well. So thank you for doing that. Um, so. And I'll also call it as an answer to this question. Rob, you're not a panelist, but you're effectively, I'm going to make you a panelist by virtue of the chat here. His comment is Medicare has been easy. Commercial payers can be difficult, but if you have your hospital reps schedule a meeting with them, the law is on the patient's side and easily gets worked out, but not without a conversation. Fair enough. And again, I think these are the kind of details that working with your uh, government liaisons, working with your team that deals with the insurance companies, as well as I think partnering with the STS and advocacy can be extremely helpful. Um, and we've brought up the toolkit quite a number of times already, but I want to drill down on that a little bit more specifically and hopefully and use this moment here as an opportunity again to sort of direct everybody to early in the chat. Our STS hosts here have included the link to the toolkit. So one by one here, maybe you could tell us how the toolkit resources have helped you. What would you direct our members here, the participants, to look specifically for and use on the toolkit that was helpful for you? Stephanie, why don't you go ahead?
Yeah. So early on in the process, it definitely helped with understanding who to talk to as far as like government liaison, who to all get on board. Again, the budget, that was a huge help as far as making the business plan and what to account for in your budget. Some things that I hadn't thought of. But it really does take you through every step. But those are the biggest things that I've utilized so far from the toolkit.
Dr. Jordan, Sean, go ahead.
I think it was still in its nascency when we started using it, but looking through there, there's a lot in the toolkit that I wish I knew when I started this process. And so I think just going through the whole thing and just reading through it, just kind of getting a big, because there's a lot of things that you don't really think about that like just like government relations and stuff, because that's not what we do. Like I had like for example, like we had a big argument here about whether or not the unit needed a sink. And it's just like silly stuff like that that you don't really think about until you're actually trying to actually put one on the road. So I think just getting that big picture framework, oh, I didn't think about that. That's what the toolkit I think is very helpful for. The other thing too is like I think there's 12 mobile programs in the nation right now. Well, I think we're going to be the 13th. Dr. Hedrick in Chattanooga, the folks at Atrium, Roswell, West Virginia, people have been extremely friendly and open in their process. So I think reach out to people that have mobile programs. They have all been extremely helpful to us as we've developed ours.
Terrific. Um, There's a couple of questions here. I think I see a bit of a theme, and that's how have each of you in this process obtained buy-in and partnership from other services involved in lung cancer screening, radiology, pulmonology? What does that conversation look like? And then on a more sort of granular level, who's running the mobile unit? Who is it a collaborative process between all of these stakeholders? Has thoracic surgery at your place really taken the lead in this process? If we could all speak to that, I think that'd be really helpful for the participants here. I'll start with you, Mark. So, Dr. Henning, go ahead.
Sure. I mean, our program might be a little bit unique. I'd be remiss if I didn't mention that this was largely, years ago, spearheaded by Mary Reed, who is a researcher with us, and lung cancer screening is her passion. And she freely says that. And so she, is what was the driving force actually behind this. And through, not hard to get buy-in from myself and my colleagues from thoracic surgery. I don't think she had a lot of trouble getting buy-in from radiology in terms of, identifying a key radiologist to be reading the lung cancer screening scans. The big hurdle was getting the funding. And once she got that, then things quickly gained momentum and were able to gain traction quickly. So kind of a hybrid type, program, I guess.
Um, Dr. Worrell, Dr. Jordan, any differences in your programs or things you want to highlight in terms of the collaborative effort with other services and other stakeholders in lung cancer?
Yeah, I think you should think about this as just an extension of your lung cancer screening program. So that's who we included. So that includes, the thoracic surgeons, the pulmonologists, our radiologists, and our lung cancer screening coordinator. And so we do a tumor board every week where we look over the lung cancer screening CT scans. And so we just have meetings during that in regards to the mobile unit. It's just an extension of our program. So buy-in from all those people was very easy because we're all pretty invested in lung cancer screening.
I would say very similar for us. I think it was driven largely by thoracic surgery here. Radiology, they had buy-in, but they also didn't really care because they didn't really change their day to day. They're still reading the same scans. They're just reading them from a farther away, so they didn't really care that much. Interventional pulmonology, I'm very fortunate that our interventional pulmonologists have a lot of passion for this, and they were on board and going to administration and advocating for this side of thing. From a perspective of the program itself, it's really run through the Cancer Institute. I mentioned that we have a mobile breast program, and it was just kind of a natural way to incorporate it under that leadership as well from an administrative standpoint.
That makes a lot of sense. So we're seeing another theme here. Great questions from Dr. Marshall, Dr. Blackman, Dr. Suzuki, all regarding how to deploy the unit. How to understand where this is best done, how to go out there, how to find a place to park the unit. These details. I think that again, Dr. Hedrick, as our honorary panelist here, has put in the chat some really useful information. I love the concept of finding local businesses or key stakeholders in the community and partnering with them, getting their buy-in. What a terrific recommendation. I'd like to go through the panel here and for you, Dr. Hennon, who's already been running a program, and then I'll go to you, both Dr. Jordan and Dr. Worrell, as you plan your programs. How do you figure out where to deploy the unit? Where is it going to be the highest yield? And how do you make sure that just operationally, where you go out with this giant thing, it's going to work? Go ahead, Dr. Hennon.
So sure, we have a nice, obviously, map of New York State, focusing on the region of Western New York, and lung cancer incidence based on the county. And so we do have some hotspot counties where significantly higher rates of lung cancer. And so those are some of the targeted areas. For us, we find firefighter or fire stations as parking lots that are kind of key to the community, have space for the unit. We have programs where we're screening firefighters in addition to folks that have significant smoking histories, so that ties together. And then, like I mentioned, it takes about 6 months of planning in advance to communicate with primary care offices, identify the patients, and then it's been good to recognize that we want to guarantee that those 20 slots are filled before committing to go there, so that it can be a maximized visit. So,
Dr. Jordan, Dr. Worrell, other additional comments?
I was just going to say you have to figure out what your catchment area is, and you don't want to screen too far away that people aren't going to come back to you. I literally just used like census data and figured out like what the smoking rate is in the surrounding counties, and I compared it to like lung cancer data, like SEER data. Like I'll like take the example of Hancock County, which is on the border between Tennessee and Kentucky. It has triple the national average smoking rate and triple the average lung cancer rate. So that's going to be a hotspot for us. Other thing that you can also think about partnering with is local departments of health. And I had a meeting with literally every Department of Health commissioner for our 22 county catchment area, and just said, hey, this is coming. We'd like to partner with you. And they were all very agreeable to it.
Yeah, I would add too, there's a lot of local like cancer communities like outside of like the big city that you're in potentially. So we have like a Native American cancer outreach group that we reached out to. So there's a lot of people that you could reach out to that are, outside of the typical rural community, urban community.
Well, terrific. Well, I promised the group at the outset here that we would stick to a 30-minute webinar and that we would try to make this high yield and short and sweet. And for me, for someone who's at the very beginnings of this process, I think the information that we've gotten from the panelists here, Dr. Hennon, Dr. Jordan, Dr. Worrell, is extremely helpful. I think one of the key takeaways from this webinar tonight is to utilize the STS toolkit, and that there's a lot of really valuable information there that covers a lot of the questions that have come up in the Q&A, actually. I would say also lean on our colleagues who have already done this or are in various processes. I would say that our panelists have all volunteered to support others in this process. I know Dr. Hedrick has given his information in the chat. And I think that as we work together as a thoracic surgical community to build this out, we can be successful here. I genuinely believe that this is sort of the next frontier of lung cancer screening, and it's a very important concept. I think there are patient populations and groups that simply just don't have access. And this is a way that we're going to provide access to populations that desperately need lung cancer screening. And as Dr. Hennon was talking about earlier, I also think this represents an initial touch point potentially just to improve our community's health in general, beyond just lung cancer screening. So really important process, really important opportunity here. So thank you everyone for joining. I would encourage you to follow up with the STS advocacy group or any of us on this panel tonight to get more information. And hopefully together as an STS community, we can build out mobile lung cancer screening and continue to cure lung cancer. Thank you all for your attendance.